can we start?
Yes.
Good morning, everyone. A very warm welcome to all of you on the behalf of Fine Roots of Dentinos. Today, we are here for the session that every dental student has thought about it at some point. What is the real scope of orthodontics? Beyond brackets and wires, orthodontics is about precision, planning, growth, modification, aesthetics, and long term impact on a patient's life. To guide us through this journey, we have with us a speaker who truly represents the modern face of orthodontics. It's my pleasure to introduce you Dr. Rutuja Khandekar, a resident in orthodontics and dentofacial orthopedics, and a content creator who is widely appreciated for making complex orthodontic concepts simple, relatable, and practical for students and young clinicians. We're extremely grateful to have you with us today, ma'am. Over to you, Doctor.
Thank you, Dr. Vanshita. Good morning, everybody. It's great to see all of you here on a Sunday morning. And thank you, team Fine Roots of Dentinos, for inviting me. So, hello, everybody. Is my screen visible?
Yes, ma'am.
Yes, ma'am.
Okay. Hi, I'm Dr. Rutuja. I am resident in orthodontics and dentofacial orthopedics. So I completed my BDS from Sihagat Dental College and Hospital in Pune, and I'm pursuing my master's in SMBT Dental College and Hospital, Sangamner. So today I want to take you beyond the brackets and wires, because orthodontics is not just about the straightening teeth. It's about function, face, physiology, aesthetics, and the long-term health. So this is how today's talk will flow, from fundamentals like growth and diagnosis to modern orthodontics, aligners, ethics, and finally the scope of orthodontics as a career. So most of the patients come and say, Doctor, I just want my straight teeth. But as orthodontists, we know that teeth are only a small part of the story. So we influence the facial balance, airway function, self-confidence, and even the quality of life. So orthodontics is not cosmetic dentistry. It is a medical, biological, and a biomechanical treatment. So let's start with the function. Malaligned teeth affects mastication, speech, and TMJ health, and it causes the abdominal tooth wear. So many patients don't realize their headache and jaw pain are related to occlusion until the orthodontic correction improves it. So the smile will directly affect the self-esteem. So I'll tell you one story. A few days back, there was this 12 or 13-year-old boy who came to our OPD. He was so sad, and his mom came with the complaint that he's not been going to school since 3-4 days because his batchmates were bullying him because of his forwardly placed upper anterior teeth. So that's how once his mind is affected because of all these things. So improved facial balance and smile aesthetic leads to a better confidence, personality perception, and a social comfort. So you'll often say patients here that, doctor, I smile more now because of the orthodontic treatment. So that's the physiological power of psychological power of orthodontics. So this pyramid reminds us that orthodontic is not appliance driven; it is a decision driven, and the diagnosis come first, then growth, biomechanics, patient factors, and finally the appliance choice. So if the diagnosis is wrong, even the best appliance will fail. So growth and development here. Growth is literally the gift in orthodontics. In class 2 cases, where the mandible is positioned behind, we can redirect the mandibular growth. And in class 3 patient, where the mandible is positioned forwardly, early maxillary protraction can prevent surgery later. So if we miss this window, the same case may become complex and sometimes they become surgical. So this is the question every dentist will have, at what age the orthodontic treatment should be started. So the first orthodontic evaluation should be done at 7 to 8 years of age. It is not for the braces, but it is for the assessment. So early detection will allow interception and habit correction and the skeletal modification. So, does every child need treatment at 7? No, but every child will definitely need assessment at the age of 7. So, why at the age of 7 to 8 is because first permanent molars and incisors have erupted and are erupting or are erupting at that age. Growth problems like underbite, crossbite, they become evident. Missing teeth can be identified and planned early. Supernumerary teeth can be detected and removed. Eruption problems of the permanent teeth can be managed early and more easily. Many children may not need immediate treatment, but the future treatment planning can begin at this age. And growth discrepancies can be treated orthopedically to reduce the need for jaw surgery later. So, what are the common problems we should watch for in children at age in the age between 6 to 8? This is the list of that problems. That is the crossbite of the front teeth, crossbite of the posterior teeth, crowding, spacing, protrusion, deep bite, open bite, underbite, and oral habits should be watched for and should be treated at an early age. So, patient motivation and psychology in orthodontics. Orthodontic success, it is a team effort. Even the best treatment plan will fail without the compliance. So motivation affects the appliance wear, oral hygiene, and the appointment adherence. That is why communication and counseling are the most important than the biomechanics. So we will see some myths and facts about orthodontics. The first myth is braces are only for children. This is not true. Braces can be done in all age groups. Is now that the adults are seeking more aesthetic appearance, the adult orthodontic is rapidly increasing. There is growing demand due to aesthetic function and awareness. So adult benefit they benefit from aligners, tats, and aesthetic appliances. So orthodontic treatment is possible at any age with the healthy periodontium. So the next myth is aligners are always painless. Aligners are not always painless. The tooth movement it is governed by the biology of the person, and the pressure and bone remodeling is the reason why there is discomfort to the patient. So pain will vary because of the force magnitude and individual response. Hence, aligners are more comfortable, but they are not pain free. The next myth is treatment will end after deboarding. This is the biggest myth patients will also have, and the BDS doctors will also have. So even after the patient treatment is over, the retention the particular patient will require the retention lifelong, because teeth will have a natural tendency to relapse at their original position, and periodontal and muscular forces influence the stability of the teeth. So long term retainers are essential for maintaining the results. Aligners work for every orthodontic case. Nowadays, we are seeing that every other BDS doctors are also giving aligners to the patient, saying this aligner will work in your case, which is not true. Aligners are effective only in selected cases. Complex malocclusions require fixed appliances or hybrid mechanics. Hybrid mechanics is where we use, for example, we can give aligners in the upper arch, and we can do ceramic braces in the lower arch. So complex biomechanics will require fixed appliances for sure. Software planning guarantees success. This is not true. Software is a planning aid, and it is a clinical diagnosis and biomechanics determine the real outcome. So the most important part of the entire treatment is the treatment planning and right diagnosis of the treatment. Aligners are always faster than the braces. This is not true. The treatment time will depend on person to person. What kind of malocclusion the person will have, and what biological type the patient will have, and not what appliance we are using. So you all have they will say that they will come to your house, they'll scan you, and they'll send you a set of aligners. but you should not promote these brands because they will not have a comprehensive diagnosis. They will not take any cephalograms, OPGs, periodontal evaluation is not there. There is no assessment of the skeletal problems. There is uncontrolled tooth movement, and periodontal damage will be there. It can worsen your bone loss and gum recession. And if there is any emergency in the mid of the treatment, they will not entertain you, they will not give you any solution to it. They will just hand you your aligner sets and they will say you have to use them, and that's it. So why orthodontist led aligners are safe is because complete clinical and radiographic diagnosis will be given to you by the orthodontist, and the orthodontist will customize the biomechanics according to your need, your malocclusion, and orthodontists will call you monthly for the regular monitoring, and there will be refinements in your aligner sets. So long term stability and retention will be planned by your orthodontist. So here the patient safety will come first. So you should always get treated orthodontically by your orthodontist and not any other BDS who has done any courses, or the D2C aligner companies. Scope of orthodontics. So, orthodontics is more than straightening teeth. It is the science of dentofacial growth, occlusal harmony, and airway development, and the smile aesthetics. The modern orthodontic integrates growth modification, biomechanics, skeletal anchorage, clear aligners, digital planning, and interdisciplinary care. So the scope has expanded from adolescents to early intervention and adult patient, increasing the treatment versatility. So orthodontics is divided into four branches, that is preventive, interceptive, corrective, and surgical. We will see one by one with the case reports. So preventive orthodontics will mainly aim at preventing malocclusion before it will become more severe. So in this phase, space maintainers after the premature loss of primary teeth will come into picture. Then your habit breaking appliances like thumb sucking, tongue thrust, mouth breathing, they will come. Then application, caries control, and maintaining the arch integrity will be there. Then early management of the crossbite should be done to prevent asymmetries in the future. In interceptive orthodontics, we have to identify the malocclusion early and intervene at the right time. Serial extraction protocol, rapid maxillary expansion for transverse deficiencies, then correction of the developing skeletal class 3 malocclusion should be taken into consideration. Then early class 2 management with growth modification by the use of functional appliances or fixed functional appliances can be done. Handling the ectopic eruption of the impacted canine should be treated at this stage. So we will see one case report where removable myofunctional orthopedics is done with the orthodontic treatment. Patient's first phase is completed till now and he's still under the orthodontic treatment. So this is a 12-year-old boy who complained of a forwardly placed upper front teeth. You can see because of that he's not able to close his lips and the lips are incompetent. You can also appreciate that the patient is having lip trap. The upper anteriors are proclined. The patient is having non-consonant smile arc. On the lateral photograph, that is the third photograph, we can see that the chin is appearing to be backwardly placed. That is, it is a receding chin appearance. The patient is having a convex profile, and the patient has a hyperactive mentalis muscle, a prominent chin appearances, chin button appearance you can appreciate. This is the pre-treatment intraoral photographs of the patient. You can see that the patient is having distal endon molar relationship on both the sides, and there is endon canine relationship on both the sides. There is increased overjet and overbite, and we can also see there are some caries on the upper molars. There are a few rotations in the upper arch, spacing is there. We took a video of this patient. Video is a visual treatment objective. To those who don't know what this is, it is basically a photograph which is taken to see, which is taken when the patient has class two or a endon molar relation and canine relation bilaterally with an increased overjet, proclined anteriors, upright lower anteriors, and uh, especially when the patients are in growing age. So we ask patient to take the lower jaw forward in a super class 1 molar relationship and take the photograph, and we assess if the facial profile is improving or not, and how he will look after the advancement of the lower jaw. So that's how it will help us to advise patient the proper treatment plan. In lateral cephalogram, we can see that the patient is in the CVMI stage 4, that is deceleration stage, where 10 to 12, 20% of the growth is remaining. So we decided to give him a removable twin block appliance with the jack screw and lower incisal capping. The jack screw was given to expand the upper arch because there was constriction in the premolar region in the upper arch. Lower incisal capping was given to patient because to avoid the proclination of the lower incisal while advancing the lower jaw. So these are the external photographs of the end of functional phase. We can see that the lip trap of the patient is gone, now becoming more potentially competent. The chin throat length, which was reduced, it is improving. These are the end of functional phase internal photographs. We can see that the overjet is reduced, the overbite is reduced. We can see super class 1 molar and canine relationship is achieved bilaterally. The upper arch expansion can be appreciated. Also, there is some lateral open bite which is seen, which will be closed in the further fixed mechanotherapy. So right now he's still under the orthodontic fixed mechanotherapy. We have bonded him. So I don't have the photographs of that. This is the comparison photograph. We can see how patient smile has changed. Patient smile has changed. He's smiling more confidently in the second photograph. You all can appreciate the chin throat length in the second photo. It is improved. The patient's soft tissue profile has improved. This is the comparison of the intraoral photographs. You can appreciate the molar relationship and canine relationship. It has become class 1. The overjet is reduced, overbite is reduced, and since the patient was in the growing stage, we advised him the removable twin block. This is another case report where we had given the patient fixed myofunctional orthopedics with the orthodontics at the same time. So this is a 16-year-old boy who complained of a forwardly placed upper front teeth. Here also we can appreciate lip trap, which is seen, because of which he's having incompetency of the lip. He's having proclined upper incisors with the non-consonant smile arc, and he has a retrusive chin appearance with the convex profile, acute nasolabial angle. These are the intraoral photographs. He has proclined upper. This is the typical case where we see proclined upper anteriors, upright lower incisors. There is spacing in the upper arch, crowding in the lower arch. Class 2 molar and class 2 molar relationship is there bilaterally. Endon canine relationship is there. But then we took a video of this patient. It was positive because the chin throat length was improving, lips were becoming competent, the lower anterior facial height was increasing. So we decided to give him fixed twin block. Here the advancement of 6 mm was done, and vertical opening was done. We gave him fixed twin block because the patient was in the maturation stage where only 5 to 10% of the growth was remaining, and we wanted more of the dental changes than the skeletal changes. So fixed myofunctional appliances will give you more of the dental changes than the skeletal changes, while the removable twin block will give you more of the skeletal changes than the dental changes. So these are the photographs after the bonding of upper arch. Then after 7 months, lower arch was also bonded. These are the end of the functional phase extraoral photographs. We can see that the smile arc has become more consonant. The lower anterior facial height is increased. Patient's chin throat length is improved. The facial profile is overall improved. These are the end of functional phase intraoral photographs. We can see that the molar and canines have become class 1. There is lateral open bite. Midlines are matching. Uh, we can see good leveling and aligning of the upper and lower arches. We had given him inclined plane in the upper arch for the retention post functional phase. These are the photographs of the current phase of the patient. He is also under fixed mechanotherapy right now. So in a few months or so, the patient's treatment will get over. So we can see that how the smile is improved. The inclination of the upper incisors have changed. The smile arc has become consonant. The patient is having increased chin throat length. The lower anterior facial height is increased. Competency of the lip is improved. Overall, the facial profile is improved. We can see that the molar and canines have become class 1. The ideal overjet and overbite is achieved. Midlines are now coincident. The spacing is closed. And final finishing and detailing will be done for this patient. So this is the comparison of the pre-treatment and end of functional phase lateral cephalogram. We can see the increase, we can appreciate the increase in the chin throat length. Patient was having vertical growth pattern, so we did not trim the twin block. So this is the second lateral cephalogram shows the post-functional phase where the overjet is reduced, overbite is reduced. So the next case report is of a rapid maxillary expansion case using the MSc appliance. It is a maxillary skeletal expander. This is a type of rapid maxillary expansion case. So a 22-year-old female, she came with the complaint of irregularly placed upper and lower teeth, and patient is having a severe vertical growth pattern. We can see she has increased lower one-third of the facial height. The upper and lower incisors are proclined. Also, we can appreciate some amount of facial asymmetries there on smiling photograph. We can see that the chin is deviated towards the right side of the face. So, surprisingly, this patient had a history of orthodontic treatment with all four extraction. So all four first premolars were extracted for this patient. This is after the orthodontic therapy. So if you get treated from a BDS, this is what will happen to your teeth. The patient's left side is completely into class 3 malocclusion, and patient's right side is in the class 1. But there is no overjet, no overbite. Patient is having open bite tendency. The maxillary arch is constricted. It is very narrow. So we decided to give patient the rapid maxillary expansion to achieve a class 1 molar, class 1 canine, and the overjet. So these are the photos for the subsequent follow-ups after the MSc appliance. So you can see how the arch has expanded. This much amount of expansion has been done. In comparison, we can see now the molars have become class 1 on both the sides. The canine is class 1 on both the sides. So this patient will also get debond in few months or so. Now we will see corrective treatment with full appliances. Fixed appliances like MBT, Roth, self-ligating, or lingual orthodontics are there. There are many options in metal brackets, ceramic brackets, in both MBT and self-ligating. Also, they are also available. Lingual orthodontics and clear aligners are for the patients who have concern about their aesthetics, or in complex cases, we give combination mechanics where hybrid aligners with orthodontic therapy is advised to the patient. We will see one case report of a patient where lingual orthodontics was done. So this is the 24-year-old patient who complained of a gap in his upper anterior teeth, but his main concern was aesthetic. His overall facial profile looks quite balanced, having competent lips, average chin throat length, and average height. Everything, the soft tissue profile looks quite good, but he was having some dental problems. We can see that patient is having anterior crossbite with the midline diastema. There is Angus class 1 molar and canine relationship bilaterally with some spacing in upper and lower arches. So, but since aesthetic was his main concern, we advised him lingual braces. So we had given first we had given posterior bite plate to the patient for disocclusion of the arches. Then we aligned the upper and lower arch, followed by the bite blocks in lower arch was given. Uh, After that, we can see that the patient is having good alignment and leveling of the arches. Then we close the spaces in the upper and lower arch. Final finishing and detailing is being done for this patient right now. He's still under the orthodontic therapy. So these are the pre and the current exterior photographs of the patient. We can see that the midline diastema has closed. Patient's smile has become consonant. The facial profile has improved. These are the intraoral photographs. We can see that the crossbite is gone. Patient is having class 1 molar and canine relationship bilaterally. Final finishing and detailing will be done for this patient. Surgical orthodontics. So combined orthodontic with surgical approach. This will be required in cases where correction of this there is need for the correction of severe skeletal discrepancies, maxillary advancement, impaction, and expansion is needed, or mandibular advancement or setback is needed, or genoplasty for facial balance is required, or correction of asymmetry is required. So this is a 19-year-old boy who came to the department with the chief complaint of forwardly placed lower jaw. So he came us telling that when he was small, he used to tell his parents about his lower jaw being forward, and his parents did not feel the need of showing this to a doctor. And hence, later on, he developed a true skeletal class 3 malocclusion, which will now need no other choice but the treatment of surgery. You can see that the lower lip is so much protrusive, the chin throat length is increased, patient is having full buccal corridor spaces, and concave profile is there. These are the pre-treatment intraoral photographs of the patient. Patient is having Angus class 3 molar and canine relationship. There is a reverse overjet. Lower dental midline is shifted towards the left. Patient is having asymmetry of the face. Also, he has an impacted canine in the first quadrant. Then there is a crossbite which is seen on the first quadrant. So this is the and OPG of the patient. The favorable, it comes into a sector 2, which is favorable. So we decided to expose the canine on the palatal side. We had bonded an attachment to it, and a partial ligation of the canine was done after the surgical exposure. So after the leveling and alignment, these are the photographs of the patient pre-surgical. So I'll show you intraoral photographs. So the extraction of upper 4 and upper 4 was done for this patient. Alignment and leveling was done, and then the patient was sent for an surgery. These are the external photographs after the surgery. So we can see now that the patient's lips, the lip step has become negative, positive. It is still positive, but it is less. The patient profile has improved. The chin throat length has been decreased. The smile, there are more corrections needed to be done for this patient. But you can see how his profile has changed. I couldn't take his intraoral photographs because he had just come from the surgery. So many corrections and many settling is to be needed for this patient. Now we will see temporary anchorage devices, that is TADs. In modern orthodontics, where absolute anchorage, minimal surgical trauma, or immediate loading is possible, it expands the treatment possibilities. So TADs are now widely used because of their wide use in the orthodontics. So they can be used for molar intrusion, for open bite distalization. For distalization, we can use bone screws as zygomatic screws, or for the mesialization in missing tooth spaces, or for end mass retraction, smile of and cant correction, where we give only one implant on the side where the cant is present, or we can give bilateral implant, vertical control in gummy smile patient. So this is a case where patient had a gummy smile, and all for extraction was done for the patient. So we had given two implants in the anterior and two implants in the posterior region. Anterior implants were given for the intrusion of the anteriors to correct the gummy smile, and posterior implants were given for the retraction of the patient. So TADs can also be used for the molar protraction. This is a case where we had extracted upper 4 and lower 5 because the patient had end-on molar relationship. So we are mesializing molar on this side. So there is a wide use of TADs. We will see one case report where management of impacted canine was done using TAD. So this is a patient, a 13-year-old girl who came with a complaint of irregularly placed teeth in her gums. So overall, her facial profile is very good. She only had the complaint of that one single tooth. So these are her intraoral photographs. We can see that the 6-3 is overeaten and 1-3 is mesoangularly impacted. And the rest patient is having class 1 malocclusion. The lower lateral incisor is in standing. In OPG, we can see impacted canine, which is appreciated in the second quadrant. We did sectors classification for this patient as well. It is sector class 2, which is favorable. Since the canine was impacted mesoangularly, we decided to give master spring, which is a mini implant assisted simultaneous torquing and extrusion and retraction spring. So as you can see in the subsequent photographs, we gave her the spring, then the canine was brought into the position. Then after that, the canine was brought into the occlusion by giving a piggyback tech was given. Here in the last photograph, we can see that the canine is now end on. So these are the end of alignment and leveling photographs of the patient. So for the space closure, and some amount of distalization was required in this case on the second quadrant. We gave her 2 posterior implants for the intrusion and retraction simultaneously. So we had run an chain from implant to 4 incisors to another implant. So it gave an effect of intrusion and retraction simultaneously with the space closure. So this is the current stage of the patient. She will get debonded in a month or so. A case report where distalization was done with the use of bone screws. So this is a patient where he is a 25-year-old patient who had complained, who came with a complaint of forwardly placed lower front teeth. He's having a competent lips with lower lip is protrusive. He is having a tendency towards the skeletal class 3, but it is a borderline case. We can see that the patient is having a class 3 molar and canine relationship. Reverse overjet is seen. Asymmetry of the occlusion can be appreciated. The lower and upper dental midlines are not matching. The lower arch is having spacing. Upper arch is also having spacing. So since it was a borderline case, we decided to place buccal shelf bone screws for distalization in the lower arch. So initially we had disoccluded the upper and lower arches. the alignment and leveling was done. Then two bone screws were placed in the lower posterior region between the two molars. But in the subsequent follow-ups, the right implant which was placed, it got mobile, and hence we had to reposition it into a retromolar region on the right side. So this is a follow-up photograph after the 1 month, and this is the end of distalization and intraoral photographs where we can see now the midlines are matching, the canine and molar have become class 1, the spaces are almost closed, and the bite will be settled. uh, Bite was settled for this patient. So these are the pre-treatment and post-treatment photographs of the patient. We can see improvement in the facial profile. The lip step initially was positive. It was positive. Now it is negative. These are the intraoral photographs pre and post treatment. We can see that everything is class 1 ideal with the ideal overjet, overbite of the patient. And also midlines are it is shifted 0.5 mm to the left side, but it is still better than the previous one. So, airway and sleep medicine integration. Orthodontics plays a major role in airway development as well. So, rapid maxillary expansion, MARPE increases nasal volume. Mandibular advancement will reduce your airway obstructions. Myofunctional therapy combined with orthodontics is also done. So, airway focused orthodontics can improve your quality of sleep, growth behavior, and attention. So, what is the scope of orthodontics abroad? If you are a BDS student who have completed their BDS in India but wants to go for masters abroad, you all can take screenshot of the slide. So these are the few exams. USA, UK, Canada, Australia, New Zealand will. There are few countries who they does not recognize our BDS degrees. So you will have to give their respective entrance exams. Then you will have to do DDS. Then after that, you can register for the orthodontic residency program. So total time will requires the total time which will be required is 6 to 8 years after your BDS in India. So after that, you can practice as an orthodontist there. So what is the scope of orthodontics? Sorry. What is the scope of orthodontics after MDS ortho? If you have done your orthodontics in India and after that you want to go abroad. So USA, UK, Canada, Australia will not recognize your MDS degree for independent practice. So you will have to clear their exam, do DDS, do their orthodontic residency program, and then you can practice as an orthodontist there in USA. In UK, you have to give their entrance exam, then you can do specialty training for 3 years, and then you can practice. In Canada, also you have to give their exam, do DDS, and then orthodontic program. Australia also you have to give their exam and local orthodontic degree should be there to practice. But in Middle East and European countries, you can give the eligibility exam and some years of experience is needed. Then you can practice. So these are the few countries in the Middle East and in Europe. That is Saudi Arabia, UAE, Qatar, Oman, where you can the Indian degrees are accepted, but experience of 2 to 3 years is required, and then you can practice your orthodontics there. Apart from that, teaching an academic career abroad is also possible. You can join as a lecturer, clinical instructor, research associate. Usually in private dental schools and universities, you can apply. It will require strong CV publications and teaching experience, and sometimes PhD enrollment should be required. In research and PhD opportunities, it is a highly promising pathway abroad. You can apply for PhD in orthodontics or craniofacial biology. There are funded PhD positions available in Germany, UK, and Australia. It will lead to your academic career and industry in research and development in maybe aligners, biomechanics, and AI orthodontics. What are the corporate and industry roles? So Indian orthodontists can work in aligner companies, orthodontic product firms, digital orthodontics and AI planning, and clinical advisory roles are there. So global opportunities with no license requirement are there for the orthodontists. What are the ethics in orthodontics? The informed consent should be taken from the patient, and realistic expectations should be asked and given to the patients. So, patient centered treatment planning should be done and not the appliance centered. We should avoid the over treatment and unnecessary procedure. Honest communication about the risk and duration should be done with the patient, especially in the surgical cases. Confidentiality and professional conduct should be maintained. Ethical use of aligners and tags and advanced technologies should be inculcated in your practice. So, when not to treat, if the patient is having poor oral hygiene and active periodontal disease or uncontrolled systemic conditions, or the patient is having unrealistic expectations about their smile. So, some patients have this body dysmorphic disorder where no matter whatever you do, patient will always feel that there is something wrong. So you cannot treat this kind of patient because no matter what you do, they will always feel there is something wrong with their treatment. Or if the patient is having poor compliance history, or patients have psychological unpreparedness, or there is a lack of long term retention commitment, then you should not treat these patients. So orthodontics is So the orthodontics is where art meets science, which is guided by the aesthetics, which is guided by the ethics. A beautiful smile is not an accident; it is a diagnosed, planned, and a treatment responsibility. Thank you so much. You all can reach me on Instagram at the aesthetic dog, and this is my email address. You all can reach out to me at any time. Thank you so much.
Very well presented, ma'am. If anyone is having queries, they can drop them in the chat box.
Yeah.
Okay. Thank you so much, ma'am, for your incredible insights. We are grateful that you provided us with the opportunity and shared your wisdom with everyone on this platform. Thank you so much for joining, everyone. For more such
Thank
webinars,
you.
stay tuned with us and make sure to follow us on our Instagrams for daily updates. See you super soon. Thank you so much, ma'am.